So, good evening, welcome back. We start the last session of today's discussion on AKI in COVID, and we are going to discuss about extracorporeal membranes. I have the pleasure of inviting Dr. Thomas Rimele, who is the chairman of Intensive Care and Anesthesiology Department at Edward Herriot Hospital, Lyon, France. He is also chairman of Department of Organ Harvesting Coordination. He did his PhD on extracorporeal blood purification therapies in sepsis, so he is best qualified to teach us about this particular topic. He's authored a number of articles on this particular topic and a co-author of more than 150 peer-reviewed articles and book chapters. Dr. Thomas.
Hello, good evening, everybody. Can you hear me?
Yes, we can hear.
Excellent. And now, can you see my screen?
Yes, I can see your screen.
Excellent. So, thank you very much for this very kind invitation. I'm very happy to be with you tonight. During the next 20 minutes, I'm going to talk about extracorporeal organ support, which is now called ECOS, for COVID-19 patients. These are my conflicts of interest. And this is the outline I'm going to follow. First of all, I'm going to give you a few information about the concept of ECOS, and then we're going to display, we're going to see together all the different clinical applications for COVID-19 patients. So what's the concept of ECOS? Well, in 2022, today, the CRT machine right here should be considered as a multi-therapy platform. Indeed, you can provide renal support in case you have acute kidney injury, and I think you've been talking about this a lot today. But also with the same platform, you can provide some therapies which are able to modulate, for example, the inflammatory response during sepsis, can modulate the inflammatory response during burns. You can also provide CO2 removal with some specific settings. You can also combine ECMO and renal replacement therapy on specific machines. You can provide liver dialysis. So really, with one machine, you can do different treatments. And actually, this is very interesting because this fits very well with the concept of precision medicine and precision renal replacement therapy, which were released a few years ago, saying that, you know, when you have a patient, you need to tailor as much as possible the therapy you give to this specific patient. You need to personalize the therapy. And I believe that these new machines, these platforms, this fits very well with this concept. So for instance, in case you have a COVID-19 patient, if you have also acute kidney injury, you can provide both at the same time, kidney support and the modulation of the immune response. If you have no AKI, but you still want to modulate the immune response and to try a new device, for example, then you can do this. And you can also, of course, do only renal replacement therapy with this machine. So when you have sepsis, just as a reminder, when you have sepsis, when you have this infectious insult, the body reacts with a double inflammatory response, with a pro-inflammatory component and an anti-inflammatory component. And the net balance is more on the pro-inflammatory side during the first hours, and then after a few hours, the net balance is on the anti-inflammatory side. It's called the immunosuppression state, also called immunoparalysis. And at that moment, the patient is extremely deleterious for the patient, because at that moment, the patient cannot fight against nosocomial infections, cannot fight against viral reactivations. The patient is extremely immunosuppressed here. All of this is due to the release of all of these inflammatory mediators, cytokines, chemokines, all the DAMs and PAMs. And the whole concept of ECOS and blood purification here is to restore the immune homeostasis with the removal of some of these mediators. I think it's important to also state here that at the very beginning, 2 years ago, that there is a cytokine storm. COVID-19 is like a cytokine storm syndrome. So it's interesting to try all these extracorporeal blood purification techniques. However, it was released in the JAMA journal that COVID-19 with ARDS, well, the cytokine levels are not that high. Actually, the cytokine levels are less important, less high than bacterial sepsis with ARDS. So I don't think it's a good idea to say this is a cytokine storm. And this word, I think, has been now removed from the literature. Well, for the COVID-19 pathophysiology in terms of inflammation, we have elevated cytokine levels, of course, but they are not that high. We have elevated cytokine levels leading to endothelial activation, leading to vascular inflammation, and increased permeability, leading to edema. And at the same time, we have the activation of the clotting cascade, leading to thrombosis, many pulmonary embolisms, you know this, and microcirculatory failure. Importantly, for what we are going to talk about a little bit later, in many patients, in many COVID-19 patients, there is bacterial translocation because of the gut leakage. And we have endotoxemia. I think this is Natasha and Professor Kellum. They reported that half of COVID-19 patients, they have endotoxemia in the blood. It's important because some of the blood purification techniques can target this endotoxemia. So I think it's also important to remind everybody this. So when I list all the different techniques available for blood purification, we can categorize them into 4 different categories. Hemoperfusion, here you have polymyxin B hemoperfusion targeting the endotoxins. You have the cytosorb technology, the LPS adsorber technology, the Jaffron technology, the Biosen technology. Hemoperfusion. You have the CRT filter. They are specific for renal replacement therapy, for CRT, but they can also at the same time modulate the inflammatory response by the removal, by the adsorption of the endotoxins or cytokines. High cutoff membranes also are also possible. It's also possible to modulate, to remove from the blood inflammatory cytokines with high cutoff membranes. Then you have high volume hemofiltration, plasma exchanges, and CPFA, but not so many publications on that in COVID patients. And then we have these new, very sophisticated therapies, which were released 1 or 2 years ago. The Seraph technology is the most recent one. 1 or 2 years ago it was released, and these ones are a little bit older. These therapies are able to remove directly from the blood the bacteria and the viruses, which could be interesting for COVID-19. So let's talk a little bit about these techniques. First of all, I will say a few words about the Jaffron technology. I won't have time to talk about all of them, of course, because I have only 10 minutes left. So hemoperfusion with Jaffron technology, what is it? It's a cytokine removal cartridge. And for example, here in this publication, it was tested in 10 patients who underwent 3 sessions of hemoperfusion. And what did the author observe? They observed that this is before the session in brown, and in green this is after the session. And here it's oxygen parameters. Well, in these patients, when the patients received the hemoperfusion, then oxygen parameters improved. And this was concomitant to a slight decrease of the cytokine levels. You can translate this also in CT scan pictures. You can see this is before blood purification, and this is CT scan after blood purification. So we can see that in some patients, the removal of all these mediators may be beneficial. Natasha Srizawat in Thailand performed a prospective cohort study with this device, with the Jaffron. This is the cytokine cartridge, cytokine removal cartridge, the HA330. He took confirmed SARS-CoV-2 infections, severe pneumonia with PO2 over FiO2 ratio below 200. And then he ran different sessions of hemoperfusion. Some of the patients received a lot of sessions, more than 3 or more. Some of the patients got low exposure to hemoperfusion. What did he observe? He observed that the patients who received the most important number of sessions in orange here, well, they got better in terms of organ dysfunctions. They got better in terms of inflammatory parameters and in terms of PO2 FiO2 ratio. With hemoperfusion, the oxygenation parameters were better. And even the mortality rate was decreased when patients received several sessions of hemoperfusion with this cartridge. Then we have the CytoSorb technology. Well, again, this is a retrospective case series, so not so robust in terms of, not very robust scientifically speaking. You have only here 50 patients requiring CRT plus CytoSorb, 10% of the entire cohort. And then there was a hemodynamic improvement in these patients. In this paper as well, the norepinephrine infusion was decreased when you compared after the session of hemoperfusion as compared to before the session. So it's very difficult to say whether or not this is due to the session or if this is just the natural evolution of the patients. Same observations for the respiratory function and the inflammation attenuation. Before the therapy, after the therapy, you can see that the PO2 over FiO2 ratio improved, the inflammation decreased, SOFA score improved, and in these 2 publications. But again, no controlled group here. So it's difficult to draw robust conclusions based on these kind of data. Then you have this registry from a US registry, 5 US centers, 50 patients. And in these centers, the investigators put together all the COVID-19 patients who received the CytoSorb therapy. What did they observe? They observed a very low mortality rate, only 17% at day 30, and no device-related adverse events were reported. So based on this data, the authors claim that there is a high survival rates when there is this exposure to cytosorbs, suggesting potential therapeutic benefit and suggesting again the need for prospective controlled studies with cytosorb. Let's talk for the next few minutes about the new blood purification device, the Seraph technology, the Seraph from the Extera Medical. How does it work? Well, the company has attached some heparin sulfate here on the beads, and this heparin attached here is able to absorb bacteria and viruses at the surface of the beads. When it's attached like this, it's important to say that there is no systemic anticoagulant activity. This is how the Seraph works. And you can see here all the different pathogens that this technology is able to remove from the blood. A lot of bacteria, but also SARS-CoV-2. SARS-CoV-2 is able to be removed by this technology. And when some Seraph sessions were applied to some COVID-19 patients who had viremia, who had a lot of viruses in the blood, then the investigators observed that after the session, the virus load decreased in the blood. Here also in this publication in blue, this is when the patients received the Seraph session. So you can see a decrease of the virus in the blood, and here in red, this is the control. The decrease was took longer to be obtained. Is it important to decrease the virus load in the blood? Yes, it is, because there is a correlation between the amount of virus in the blood and the severity of the patients. Here you have patients who are in the ward or outpatients, not so much virus in the blood, but in the ICU, the viremia is much more important. So the idea that something is able to decrease this virus from the blood may, of course, be of interest. So when to apply the Seraph cartridge? Well, as soon as possible when the patient arrives in the ICU. Right here, infection, hospitalization, patient needs the ICU, then you can start as soon as possible when you want to, again, target this virus from the blood. There is, with the Seraph, you have two registries that were published. The first one in the US, 100 patients, and I'm sure there are much more patients in this registry. And interestingly, look at the difference of survival between the patients who received the Seraph, the COVID-19 patients who received some Seraph stations, as compared to controls. And interestingly, in Europe, you have the same, another registry, same patients and same observations. Survival was much better when the COVID-19 patients received some Seraph sessions. How to use the Seraph? You can use the Seraph only when you place the cartridge on the machine and you use it as a standalone configuration, or you combine the Seraph technology, Seraph hemoperfusion, with your station of CVVH or CVVHD or CVVHDF. You can do both at the same time. And interestingly, you can use all the machines you want. You can use the Fresenius machine, the Baxter machine, the Bibron machine. They are all compatible with the cartridge. In conclusion, I would say that regarding echoes for COVID-19 patients, the pathophysiology is much more complex than just a simple removal of very high level of cytokines, because this is not existing. There is no cytokine storm in the majority of patients. You have we have different extracorporeal blood perfusion devices available. They do not target all the same things, but they definitely need to be assessed in studies with control groups, because we have too many case series, too many observational studies, although it's only 2 years from the very beginning of the pandemic. So, but now we need to get studies with control groups to get more robust data. And with that, I would like to thank you very much for your attention.
Thank you, Dr. Thomas, to introducing the topic on ECOS. I now have the pleasure of introducing Dr. Lobo, who is very well known to everyone in India. And when any nephrologist in India has a doubt regarding the membranes or the details of a hemodialysis machine, they generally call him up. He is the head of the Department of Nephrology in KEM Pune. He also has keen interest in atypical HUS and one of the few centers in the country who have the wherewithal to do the tests for the complement, rare complement levels and other factors involved in the HUS. Dr. Lobo, please proceed with the topic on newer membranes in COVID-19 AKI Indian experience.
Thank you, Dr. Rajshekhar. Is my screen visible?
Yes.
Yeah. Thank you very much also for the opportunity to share a very small Indian experience that is available from the literature and also our own personal experience.
Please make it full screen. Slideshow mode.
It is saying screen sharing is paused. I've made it full screen. Is it moving?
No.
No.
The first slide is seen.
I'll just retry it.
Yeah.
Is it okay now?
Still, we are seeing it as the minimized version only.
I'm seeing a full screen, but it's giving me a message, your screen sharing is paused.
Can you retry?
Sir, please close that PPT and then once again you open, sir.
Okay, I'll do that. Is it visible?
It is visible as a smaller, this one, not a full screen.
Okay, there is a way of doing it which I'm not getting. Can your technical person tell me which window to select? I think I'm selecting the wrong one.
The first one, before 47%.
Before 47%, okay.
Bottom, in the bottom.
That he's clicking the correct one only.
I'm clicked that. It's showing me a full screen now.
Okay. Do we have a recorded version?
No, it didn't record. I tried that. Now, when I select from share screen, PowerPoint slideshow, Is this okay?
Get to see the screen. It says.
Yes, sir. Yes, sir.
Now it is.
Okay. Okay,
Yeah,
fine.
please
Then I'll
continue.
go ahead. Yeah. So, as we just heard from Dr. Emela, there is in release of cytokines, though not as high as in sepsis. And for a long time, IL-6 was believed to be the central player in this, which is why tocilizumab came in very early as a therapy. Now, the molecular weight of most of the cytokines is between 17 and around 30 kilodaltons, and most of the membranes available for cytokine removal can remove molecules up to about 42 to 45 kilodaltons, that is the lambda light chains. They will not remove CRP, which has a molecular weight of about 120 kilodaltons, and which is what we have been recommended to monitor the levels of while assessing the response of the patient to therapy. There are 4 devices available in India to us. The first is the polymethyl methacrylate dialyzer and hemofilter, Hemofil, which is manufactured by Toray. Dr. Emela spoke about the HA330 from Jaffron, which is a Chinese device. The Oxiris, which is a dedicated cartridge for CRRT, only for use on the PrismaFlex machine, and the Cytosorb device, which is beads, polystyrene divinyl beads for adsorption. Of these, the Hemofil and the Oxiris can perform both renal replacement therapy as well as immunomodulation, possibly, whereas the HA330 and the Cytosorb device cannot give us any form of renal replacement therapy. So there is one study which looked at a comparison of Oxiris, Cytosorb, and the Toremixin device in reduction of IL-6. And Oxiris caused about a 93% reduction, Cytosorb 99%, and Toremixin, of course, because it targets endotoxin, was much less efficient in cytokine removal. The first experience that we had with the Oxiris in COVID-19 was in this patient back in July 2020, and which was published in the Indian Journal of Nephrology. This was a 77-year-old patient who was admitted to KEM hospital on the 14th of July with loss of appetite, weakness, cough, fever, and dyspnea. In the emergency room, he was found to be hypoxic, required oxygen via mask at about 6 liters per minute, and his PO2 was 52 at the time. His blood urea was 145, creatinine 11.73, and his ferritin was more than 1200, CRP 140, D-dimer was very elevated, and his IL-6 level was about 40 times the upper limit of normal. His urine culture grew E. coli, and so he was imaged, and his RT-PCR was positive for COVID-19. He received remdesivir, cefoperazone, sulbactam, heparin subcutaneously, and methylprednisolone, which was the standard of care, and was dialyzed initially with a polysulfone high efficiency dialyzer on 2 occasions. Following this, there was a reduction in urea and creatinine, but the patient's sensorium worsened. He developed myoclonic jerks. He became more hypoxic and had to be switched to a high-flow nasal cannula oxygen at 50 liters per minute. And a CT scan, which was done, showed no fresh lesions. So his antibiotics were upgraded. His serum creatinine at this stage was about 7, and he was taken over for CVVHDF on the PrismaFlex machine using the Oxiris hemofilter. We started removal of fluid at 50 ml per hour. That was the ultrafiltration. And the effluent total dose, or the dose of CRRT was getting, was 37 ml per kg per hour. The Oxiris cartridge lasted for 57 hours, giving us about 5 liters of ultrafiltration, and the IL-6 decreased by about 85%. His Glasgow-Coma scale improved from about 8 to 12, and his urine output also improved to 100 ml per hour from an oliguric condition. So this is the Oxiris membrane. It has polyacrylonitrile as its basic membrane, like the M100 for use. In addition to that, it has a second layer of polyethylene imine, and it has heparin bonded. It's a large membrane, about 1.5 square meters, and it has been shown to have at an effluent of 1 liter per hour, a urea clearance of 17 ml per minute, and at 2.5 liters per hour, which is what we use in our patient, 42 ml per minute. We kept the blood flow a little higher than normal at 200 ml per minute in order to minimize the filtration fraction down to 20%. We used heparin at 500 units per hour continuously infused on the Prismaflexizone heparin infusion system. And at about 13 hours, the transmembrane pressure was just 80 with these settings. And this was preserved until pretty much about 52 hours, at which the transmembrane pressure began to rise, and we electively stopped the treatment at 57 hours. After stopping, the patient needed 2 additional dialysis sessions, following which he recovered. He had a baseline chronic kidney disease, and he recovered to a creatinine of about 4.5, on which he was discharged and remained dialysis independent a year later. This is what the course of his treatment showed. We started CRRT when the CRP was 140 and the interleukin 6 level was 240. The interleukin 6 level dropped to 38 after the end of the CRRT 57 hours and then rose slightly to about 68, but the CRP came steadily down, and also his oxygenation continued to improve. So initially he had a PO2 while on 50 liters of oxygen of around 111. After CRRT, the HFNC oxygen came down, then he was switched to a mask, and eventually he was on to breathing ambient air. After this, we did 22 patients, all of whom had a need for high frequency oxygen, nasal cannula oxygen or ventilation. We only took patients who had conventional indications for renal replacement therapy, either AKI or A1CKD. All of them had CRPs of more than 60 or rising. All of them had D-dimers, which were more than twice the upper limit of normal. And we managed to do IL-6 levels in a good many of them. 9 patients received 10 sessions of Oxiris CVVHDF, and 13 patients received SLED or SLED-F with the hemophil dialyzer. These are our patients who received Oxiris hemofiltration. 1 patient received 2 sessions. The rest of them received 1 session. 2 patients received 2 sessions. The rest received 1 session each. The average duration of the hemofilter, of the Oxiris hemofilter, the average life was about 36 hours, up to a maximum of 91 hours in 1 patient. This morning, when I listened to Brigadier Nair, who said that most of the CRRT patients did poorly, I think this is the reason. All of us start CRRT in those patients in whom all other therapies had failed. So all of these patients were on 2, only 1 patient was on 1 pressor agent, and there were 3 patients who were on 4 inotropes at the time of starting. We found that the higher the IL-6 initially, the better was the reduction with Oxiris, while the CRP showed a more uniform reduction after the therapy. There is one report from Dr. Yatin Mehta's group on the use of Cytosorb. The DCGI approved emergency use of Cytosorb on 6th May 2020 for COVID-19 patients with confirmed or imminent respiratory failure. And this report from Dr. Mehta's group, which was published in 2021, is of 3 patients. All of them clearly had multi-organ dysfunction. All of them received all other therapies like HCQS, tocilizumab, plasma infusions, dexamethasone, IVIG in one of these patients, after which they were shifted to this form of therapy. Now, all 3 patients received a single Cytosorb cartridge. The report says SLED was done in 2 of them. I'm not sure whether this means that the Cytosorb was coupled to the SLED or whether they are referring to the duration of therapy. And all these 3 patients improved to hospital discharge. In this report, there was a modest reduction of CRP with the Cytosorb therapy, but there appears that at least in 1 patient, there was a rebound after stopping the therapy. And with IL-6 levels, which they have reported over 4 consecutive days on 1 patient only, it doesn't appear that Cytosorb produced a remarkable reduction in this patient. The IL-10, which they studied in 2 patients, was also moderately reduced by Cytosorb. After this, we did a study in 13 patients using the polymethyl methacrylate hemophil hemodialyzer. These dialyzers are supplied free to us by the Torre company. We included all patients with severe COVID-19 infection who had hypoxia, who were either requiring HFNC, non-invasive or invasive ventilation, had rising CRP levels, and they had to have acute kidney injury or acute on chronic kidney disease with a conventional indication for renal replacement therapy. The initiation and prescription was done by the nephrologist. The blood flow averaged about 150 to 200. We kept the dialysate flow at 300, and all these patients received extended sessions of 6 to 10 hours. This is the polymethyl methacrylate filter, 1.8 square meters with a very high ultrafiltration coefficient, 48 ml per minute per millimeter of mercury. It is recommended at a use of a blood flow of 200 ml per minute. It gives a urea clearance of around 192 ml per minute. Initially, we were doing sustained low efficiency hemodiafiltration. Then the company requested us that you don't need to do this because it's adsorption and not convection that removes all these inflammatory mediators. So we switched over to doing SLED in these patients. This is how we ran it. We used to give replacement fluid through independent pumps. We used inotropes to maintain a mean arterial pressure of more than 70 and measured IL-6 levels before and after each session and CRP levels every 48 hours. All our patients received standard of care. The primary outcome was mortality at 30 days, and the secondary outcome, improvement in oxygenation at day 3 and 7. The average age of our patients was 67 years. The average APACHE-2 score was 30. The ferritin averaged 1236, and the D-dimer was close to 4500. There were 2 transplant patients, 1 renal transplant, 1 liver transplant patient, 1 patient who had HIV, and there were 5 diabetics and 1 decompensated liver disease patient. The 5 of the 13 patients received invasive ventilation, 3 non-invasive, and 1 patient HFNC, and 6 patients were not NC, and 6 patients were not on inotropes, while 7 of them were receiving some degree of inotrope support. The indications for renal replacement were largely metabolic acidosis and hyperkalemia, and in 2 of the patients, it was pulmonary edema, and in 1, it was encephalopathy. We did 32 sessions in 13 patients, so the average was about 2.5. The average blood flow was around 200. The dialysate flow was deliberately kept at 300, and the net ultrafiltration over a 6 to 10 hour session was little over a liter. There was a marked reduction of IL-6. The blood urea nitrogen also reduced significantly, as did the creatinine. So the dialysis efficiency was confirmed. And this is what happened to the IL-6. As with Oxiris, we found that the higher the initial IL-6, the greater was the reduction with this form of treatment. And the CRP, which is not removed by any of these filters, also fell significantly after 2 sessions of hemophil SLED. 5 patients died, 8 of them recovered to ICU and hospital discharge. The predicted mortality from the APACHE-2 score was 62. The actual mortality was 38, giving us a standard mortality ratio of 0.61 with a 95% confidence of 0.25 to 1.35. This is a Chinese study which had looked at Oxiris and shown that with Oxiris also procalcitonin, IL-1, IL-4, and CRP all fell. IL-6 fell significantly, IL-8 not so impressively, and TNF-alpha only studied in 2 patients. So what did we find? That patients with AKI and severe COVID-19, the STOP COVID trial published in JASN last year said that the mortality was around 60%. In our patients, we had a mortality of around 40%, and other studies with using Oxiris by Zhang have also shown a stabilization of hemodynamic status and a staged improvement of oxygen. Of course, this is a very limited number of patients, and there were very heterogeneous treatments because we weren't in charge of all the other treatments. So there were patients who received treatments like colchicine, immunosine alpha as immunomodulators, and we don't know how this might have confounded the study. In summary, Oxiris, Cytosorb, and Hemophil appear to achieve a significant reduction in IL-6. There is also a reduction in CRP, a molecule which is not removed by any of these filters. We noted an improvement in oxygenation in all the survivors. It looks interesting that case series and small studies indicate a clinical benefit. As Dr. Imella said, a randomized control trial will be needed to show that there is truly a benefit of these treatments. Because I always remember that I look at these studies, all the studies in sepsis which used extracorporeal therapies, and none of them, unfortunately, showed us a significant clinical benefit. And in fact, 3 of them showed a signal of harm. Thank you for a patient listening.
Thank you, Dr. Lobo, for summarizing the data from your center and the country. I have the pleasure in introducing a person who does not need any introduction, Dr. Ravi Mehta, to talk about best practices for CRRT, lessons learned from COVID-19 pandemic. He is the Professor of Medicine in Division of Nephrology and Associate Chair for Clinical Affairs, Department of Medicine, University of California, San Diego. All of us know him as one of the most published men in AKI for several decades now. He did his MBBS from Amritsar and then nephrology from PGI Chandigarh, graduated from University of Rochester in nephrology, and subsequently has been in San Diego on faculty of UCSD since 1988. He's founding member of AKIN, ADQI, and most of the data that we have been exposed to or growing up seeing the Picard group data he's one of the founding members of Picard group. Over to Dr. Mehta.
It's a pleasure to be participating in this virtual conference, and I will be talking in the next 15 to 20 minutes on what we've learned from best practices for CRT during this COVID-19 pandemic. These are my disclosures, and they don't have any relevance to this talk. What I will cover is three areas: the epidemiology, the management and adaptations of renal support therapies, which has occurred in COVID-19. When we think about the possible options, they are the same as we would use for everywhere else, including intermittent dialysis, continuous dialysis. Intermittent dialysis applied for longer durations, known as PERT or SLED, and then peritoneal dialysis. But what you can see here is the applications within each of the COVID-19 pandemics has evolved to meet the need and the demand in these patients. We know from a meta-analysis that to a large extent there was a significant increase in AKI in these patients. Sorry about that. In these patients. And the pooled prevalence of acute kidney injury was about 28%, with those in the ICU almost 46%. However, about 19% of the patients in the ICU required dialysis, whereas 9% overall. But in terms of the kidney replacement therapy, the vast majority of patients got intermittent dialysis or continuous dialysis. Very few were treated with peritoneal dialysis. This is one study for peritoneal dialysis from the UK earlier in the pandemic, showing how they managed a few of these patients over their institution, but also recognizing that in these patients, almost about 30% of them had to be switched to CRT or intermittent dialysis without turning to peritoneal dialysis. However, they did make some adaptations in the therapy itself with respect to the prescription protocol, as is shown in this table, both with respect to gradually increasing the volume before leaving an indwelling volume overall. And they found that there was a reasonably good chance of recovery. What we do know, however, from two other studies is that essentially that patients who had COVID-19 and acute kidney injury, the overall mortality shown in this study, overall mortality was about 11%, but those requiring dialysis, it was about 5%. But when these patients required dialysis, as shown in this study, there was a significant increase in requirement in their mortality risk. But also, these are the risk factors for acute kidney injury and CRRT. As you can see, significant risk factors for dialysis requirement are both in terms of gender, the BMI, presence of underlying CKD, and also the PaO2 FiO2 ratios and the requirement for D-dimers as such. When we look at one other aspect of the epidemiology of RRT in COVID-19, it is quite significant that the vast majority of patients had started renal replacement therapy in the setting of intubation. So immediately post-ventilator requirement, the requirement for AKI-RRT increased and was timed according to that. So this is something that we need to consider all the data subsequently. When we go to the management features, and when we look at it in that context, we started using RRT therapies for both parameters. And as I've seen in the prior two talks, the disease modification aspects, particularly with respect to, has already been covered. But when we think in features of CRT, the availability made this more of a normal choice of patients in the ICU wherever this therapy was available. And this also allowed to a more multidisciplinary approach in these patients. However, some of the challenges that were faced when COVID-19 pandemic were both the surge in the number of patients in the ICU, challenges related to the COVID disease state itself, and more importantly, something which had not been seen previously was a crisis of an RT provision, both with respect to reduced filter life, limited resources, and the need for rapid adoption of unfamiliar techniques and for rapid training. So I'll try and cover these in a little bit more detail. When we think about the adaptations which occurred as such, what's important to recognize is that the pandemic led to both an increase in the demand for renal replacement therapy and also a simultaneous reduction in at a local, national, regional, and a worldwide level. And this resulted in a potential crisis in RT provision with influence. When we look at this in this way, then I'm going to just cover this with respect to 4 possibilities. The technical considerations which were adapted were related to more for machine placement and infection risk associated with aerosol transmission. And since these therapies, particularly CRT, require nurses to be monitoring them on an hourly basis, it led to the thought process, well, could we position the machines outside of the ICU room? And as a consequence, this was utilized in several centers. The machine was placed. This situation, they had the renal recovery was only about 39%, but a pretty high mortality rate and significant increase in leaks as such. But even in this situation, what they did was place the machines outside the room, my apologies, outside the room. And you can see here's the PD cycler placed again, but instead of using a drain line, they put drain bags so that they could monitor the patient significantly. So these adaptations were more for infection control. A second aspect of adaptation was in terms of operational characteristics for respect to the access, the anticoagulation fluid management, and the dose for shortened duration. Now, a significant number of these patients required prone positioning. And in this case, placing the access so that it could be evaluated and also provide the significant amount of blood flow made it a little more difficult. Consequently, people came up with some adaptations. So this is just one study showing how they utilize a popliteal vein access in the popliteal fossa, again, providing the same level of access for continuous therapies as you would have had with an internal jugular vein. Now, I'm not sure that other centers have followed this, but it just shows the innovation which occurred because of the changes in the pandemic itself. What was more important was the dramatic need for adapting anticoagulation strategies, because with COVID-19, a significant number of the patients had a hypocoagulable state, probably related to the increased D-dimer and the other aspects which are going on. Now, what's important to recognize that regardless of whether it's COVID or any other situation, one needs to take care of the filtration fraction as a component for maintaining anticoagulation. And I just want to re-emphasize this. The filtration fraction is the difference in the ratio of the ultrafiltration rate to plasma water flow rate. And generally, you want to keep this as about 25% or lower, because if you go up higher from this, the viscosity of the blood exiting from the filter increases the chance for clotting in the filter. Now, in these situations here, for the COVID-19, what was seen is that even though that they were using no anticoagulation strategies or citrate, they required systemic heparin to be added particularly in these patients as such. And you can see there's a variety of studies which have been done here showing you that regardless of the citrate use, you needed to add additional utilization here. And this led to the development of several protocols. I just show you two of these here. This is from the Weill Cornell Presbyterian Columbia group, where they had shown that they were different. They were starting everybody on 500 units an hour regional heparin, regardless of all the other integration strategies. And similarly, in the Emory protocol, they had a combination of the heparin and citrate protocols itself. By the way, all these protocols and a lot of other material is available on the CRT online website, for free access for future reference itself. We had an AKI conference in 2020 at the time this was going on, and then in that we suggested that the initial CRT anticoagulation protocol would depend upon local protocols. However, as a first level, as you go to a second level CRT anticoagulation, you may need to add increased heparin intensity, and as a third line, continue to add more and more anticoagulation strategies itself. This did not matter with which therapy you were using. What was particularly pertinent when you were using continuous dialysis itself. And most important was having a good vascular access. The next area, which has sort of not been as well described, is fluid management strategies. And this is because, to a large extent, there's still some concern in terms of whether COVID-19 states lead to two different phenotypes with respect to fluid, their hypoxemia. Is it because of dysregulation of pulmonary perfusion with a phenotype L versus a pulmonary edema, collapse, ARDS, like with a phenotype H, with pulmonary microthrombosis being an element for this? And in these situations, obviously, the question was, how do you manage fluid, and what fluid levels would you remove, and how frequently would you adjust these? This is still something which has not been well described in the literature, so I don't have any specific evidence to suggest to you that one approach or the other is beneficial. What was actually happening in this situation was the therapeutic targets were being managed a little differently. And for this, you've already heard from Dr. Rimele and Dr. Lobo, their approach to this. But we look at the targeted extracorporeal blood purification options in terms of the stages of the disease. For moderate to severe disease, the thought process is the whole element is to try and prevent or mitigate organs damage. However, this relates to then the opportunity of having some aspect of working on the circulating mediators and for managing the consequence of this on multiple organ failure. When we look at this with respect to the approaches that could be used, is obviously if cytokine manipulation is one of the aspects, then this treatment strategy would be adsorptive membranes, as you've already heard as such. But more importantly, we also simultaneously want to be able to support organ function, and this will lead to the combinations with veno-venous ECMO or with extracorporeal CO2 removal. And here, considering that these therapies by themselves don't affect fluid management, one would need to also adjust what's happening in terms of fluids and also the solute loads itself. However, what we found to a large extent was that despite the recommendations of how we might manage them, several companies got emergency use authorization from the FDA. So this is, for example, the Oxirus device from Baxter. This is the CytoSorb device, and then also the device from Xthera, which was for EUA. However, we don't have a full detailed evaluation of any comparisons across these devices, and you've already had a summary of these from the previous speakers, so I won't dwell on it. Nevertheless, to say that the pandemic has forced into the forefront the opportunity for using adsorption as a therapeutic modality and not solely depending on convective and diffusive clearances in this setting. One of the next things that we also learned from this was, in essence, that there are patient-specific considerations which are really important, not only for COVID, but in any situation. These relate to timing of the RT initiation with respect to what the patient needs are and the availability of staff and equipment, and then also timing and the dosing aspects, both for solute and fluids, and specifically for COVID-19, the hypercoagulable state as such. One area which I think then is important to then, which was really unique overall, was how to manage the scarce resource modifications with respect to both equipment, the staffing, and also for crisis management allocation itself. Now, during the pandemic itself, this study was done to just estimate what would be the total approach to machine availability and personnel availability across the US. So they did a model on this based upon simulations of continuous renal replacement therapy demand and capacity from February to August 2020. And they did these projections in 6 US states and as such. And basically they had 2 simulations on the demand. If all patients with AKI stage 3 requiring ICU care, and then also the capacity of the available ICU beds and CRT machines. And based upon this aspect, they had sensitivity analysis and predicted there would be almost 1,000 CRT machines, which would be short at the peak COVID-19 US rate. And when they showed this in this publication, you can see they had a base case scenario, a best case scenario, and then the worst case scenarios. And you can see that all these red states would have suggested they would have shortages. And we actually did see some of this happen in the US, in New York state itself. What this then led to is a suggestion of how did people adapt to this? So this is data from Molly's Osterman's group in St. Thomas Hospital, where one of the issues was, well, even if the machines were available, would there be adequate amounts of fluid available? So they actually developed a fluid composition of 2 very simple solutions of sodium chloride, 2 liters, with sodium bicarbonate, and then you had sodium bicarbonate with sterile water, and this is the Formula 1 and Formula 2. And what they were able to utilize in this particular situation was a adaptive protocol that they started patients at RRT initiation who had a serum potassium more than 6.5. If they did not, they went to a commercial dialysate solution with potassium of 4 millimoles per liter. But if they had a high potassium, and here on this table too, you can see to a large extent that the fluids were compatible with the citrate-based anticoagulations, and they were with non-citrate anticoagulations. And in both these instances, by utilizing these 2 simple ways of adjusting the potassium levels, they were able to achieve an adequate balance in these patients. So this is again suggestive of how innovative strategies emerged. And what you see here is the changes in electrolytes, acid base, and glucose from baseline to 6 hours was all within the parameters of what would have been expected in these patients, even if testing and repeat chemistries for 3 samples did not find any evidence on any infection control. And they've been using this modality for quite some time. However, when we look at this with respect to another study which was published around the same time, almost now about 12 to 14 years ago, we see that if you were to look at sampling sites across the circuit itself, and you take samples at different time points, what you find is that you do start seeing endotoxin, you do start seeing colony counts, and as shown in this electron microscopy, you can see that there are presence of biofilm fragments on the tubing surface and also bacteria. So it isn't so much that the dialysate itself is a problem, it is that the contamination occurs at every time point on the circuit. So therefore, with a generally sterile solution in a bag, you may have a lesser chance of those happening than with on production of an online solution. However, several centers have been using this during the pandemic itself. A third aspect was in terms of the shortage of machines and staffing. So this is really evidenced very well from the New York City, Columbia University. And I just point out to you in this table here is, so this is in April 2019, before the pandemic, a year before. And you can see that they had a number of nephrology clinical services, 6. They had about 911 hemodialysis treatments, and about CRT cases per day were less than 24. But during the surge, they had over 67 CRT cases in a day, and they had to expand all of these services itself. And here, so at baseline, when they had only about 27 nice CRT machines, they needed almost 73. And you can see this big surge in requirement over the time when this was happening in April last in 2020. Now, what they did there is to manage this, they created dashboards. And this dashboard was saying as well, if you have to utilize these machines across so many patients who need them at the same time, they did quite a few things. So they started sharing machines. They started having one machine for 2 patients, each person on for like 12 hours. They knew where each machine was going into different ICUs, but this was tracked with a centralized dashboard so they could see what was happening in the setting itself. And essentially, when you look at the sharing protocols overall here, you can see that they were able to manage these patients with different elements itself as you went along this part. So during the surge conditions, I think one of the things which has come here is that we need to be able to have both the indications, the modality, and the RRT dose were all adjustments that were made to be able to accommodate this aspect as such. And the recommendations based upon the AKI were essentially this needed to be streamlined at each local level, taking into account what was available in that setting. But I think the last part of this was also the thought process is that when and how for CRT, the adaptations for COVID-19, if you had no staff and you had no machines, or the crisis was that there were too many patients and all had to share. So we, at UCSD, for example, we created a system where you had this contingency that if the nursing was short, you could shorten the intermittent dialysis sessions. You could utilize a different way of stable patients being transferred. If the contingency was machines and fluids, how would we manage that? And if there was a crisis where we had to choose which patients would survive or which would benefit most overall, this being the most difficult aspect, but we had a plan in place, which has still been in place there in the case we get to this level. We did get to the contingencies of the yellow and the orange, but fortunately have not had to deal with this. But what the goal of this is to recognize that we do need to be prepared for such protocols, for such events, and have protocols in place to manage these patients itself. So what we need to think about in terms of RT during surge conditions is not only to have the increase in RT demand and reduced RT capacity, but think about what the goals are, develop a local response, and then translate that to a regional or national response. Now, obviously, this is quite difficult in situations where different centers have different resources, different protocols, different aspects. But at the very least, at each center, it's important to have these goals and the local responses teased out and put in paper so that they can be implemented overall. And then hopefully this can go to a more national level as such. So I'll stop there. Finally, what I'd like to just leave you with is some of the lessons we've learned. We need to be flexible in the approach, considering the targets for support, the practical considerations, and the availability of resources. And we know that surges in COVID-19 cases can limit the hospital resources. We had multiple waves, and we are in the midst of another wave right now. But what's most important is we are starting to see new innovative aspects which are coming in.
Thank you, Dr. Mehta. With that, we will move on to the next talk. I have the pleasure in introducing Dr. Sumit Mohan, who is a nephrology specialist in New York and has 23 years of experience in the medical field. He graduated from Kasturba Medical College in 1999. Presently, he is affiliated with New York Presbyterian Weill Corner Medical Center. Dr. Sumit, please.
Thank you, Dr. Chakravarti, for the invitation and the opportunity to present. Let's see if I can share my slides. Hopefully you can see my slides. So thank you again for the opportunity to present. So the topic I was given was dealing with an acute RRT surge, what's needed. You've heard from Dr. Mehta some of these details, but what I'm going to do is try to provide a perspective of what a pandemic surge response would require and how we went about doing that. So just as in terms for 2 years, but we were looking at very high hospitalization rates for those patients who did turn COVID positive, and unfortunately high mortality rates, particularly among the older individuals. So Columbia University is, the medical center is in the upper northern corner of Manhattan in New York City, which, as you can see from the figure here, was in one of the more severely affected parts of in the first month, we had about 11 to 1,200 COVID positive patients admitted, all of who were hypoxic, the majority of who eventually ended up being intubated. So in a surge setting, we had stopped all our elective procedures, elective admissions. We had converted all our operating 200 patients being followed by the nephrology consult services. We had about 110 patients at our peak on some form of renal replacement therapy, including about 67 patients on requiring continuous renal replacement therapy, either because they were hemodynamic stable or because of kind of our surge setting, and I'll talk about that. So just as a very brief overview, we recognize that these patients do very poorly. So AKI with COVID does not do well. As you can see from this data, renal replacement therapy requirements started to peak about 10 days after onset of COVID symptoms, or that usually ended up being about 5 days, between 5 and 7 days after presentation, depending on when these patients presented. And outcomes were dismal. So not surprisingly, people with high SOFA scores did particularly poorly, but in general, regardless of the SOFA score, the need for renal replacement therapy was associated at the time with about a 50% mortality rate in our cohort. And there are many things that we still do not fully understand about AKI and COVID. As you can see from data from David Chardon's group at NYU, there's a dramatic increase in D-dimer, and D-dimer levels and elevated D-dimer levels are associated with worse prognosis, both AKI and worse prognosis. We've also noted, a dramatic increase in hypermagnesemia in these individuals, and those individuals with hypermagnesemia both have an increased risk of AKI, but also a much higher risk of mortality. Which is an interesting observation, but one that remains to be explained. And this was not unique to New York City. This is an early meta-analysis done by my group that showed that essentially when you looked at all of the early publications early in the pandemic, mortality rates for those individuals with COVID and AKI was quite high. We were talking about an odds ratio of 15, which is a remarkably high odds ratio in general. And so when you're looking at severe AKI and you're looking at high mortality rates, it's not surprising the renal replacement requirements of these individuals was also high. So as we all know, there are different renal replacement therapy modalities and strategies that can influence these decisions. Each one of these, whether we're talking about intermittent hemodialysis or traditional CRRT that runs continuously, or some form of hybrid renal replacement therapy or acute PD, all have their pros and cons. Some of it is limited to kind of the resources. And so this is somewhat dependent on the institution and what you have as your standard ability or capability to manage patients with renal replacement therapy. But at least in the United States, where we have a reasonable size CRRT program for patients in the ICU, and unfortunately don't have good acute PD, the tendency was to move towards these hybrid RRTs and in extreme duress start these acute PD programs, which are a particular challenge when there isn't enough experience on the ground. So when you're faced with a resource surge, what does this require, right? So there are multiple aspects to it. So the first thing is the expansion of clinical services. So when we are dealing with not 60 and 70 patients on a consult service, but we're dealing with a tripling or quadrupling of the number of patients we're following, it's essential that we try to understand that you probably need to reorganize how your traditional clinical model works. So at Columbia, what we ended up doing was we moved to a geolocalized model. So we were able to carefully follow censuses, but that meant that we were following patients in one place as opposed to having an acute kidney injury service, a hemodialysis service for ESRD patients, a separate service for the glomerulonephritis and the consult service, so to speak, or a nephrocard service. So that sort of model just would not work in the middle of a surge. And because of the large number of patients, we ended up needing to expand the number of services. So a service is essentially an attending, or what the rest of the world would call a consultant, and a trainee that was following a predefined number of patients in a location. We got rid of weekend on calls. We moved to a week on, week off, so it would limit the number of transitions of care for patients. and also limit provider fatigue. Remember, we're talking about a situation where early in the pandemic, it wasn't even clear whether there was droplet precautions, whether COVID was aerosolized or there was transmission of surfaces. So it's quite remarkable how little we knew at the time. Similarly, when you have a dramatic increase in RRT needs, you're going to have an increase in staff requirements in terms of dialysis nurses, nurses in the ICU that are able to manage these CRRT machines. And there are staff quarantines and infections that are constantly playing havoc with your human resource planning. And in these sort of stressful environments, it's frequently necessary to kind of obtain other human resource options. So, for example, priming and setting up CRRT machines and troubleshooting them. If you can move that burden off nursing staff in these sort of stressful environments, that's helpful. So we took the folks that we thought would be the easiest to train on these CRRT devices, and so cardiac perfusionists, given that we were doing no elective cardiac surgeries at that point, were kind of reassigned to managing our CRRT pools. Similarly, we borrowed dialysis nurses from outpatient dialysis units, on a locum basis to try to supplement our nursing manpower. And then finally, there's the challenge of consumables. So when we tripled our renal replacement requirement, you're also going to go through your consumable supply rate much, much faster. And so that's something to think about. We got, and I'll talk about what those options exist. We got fortunate in some ways that we were envisioning an increase in our CRT service across our ICUs for other reasons. And so we had an order for additional CRT machines already placed. And that was, I would say, just sheer luck that we had more machines available. But even with those increased number of machines, we did fall quite short. And so we had to come up with some innovative strategies to ensure that patients who needed renal replacement therapy in the ICU got it. So because we fell short, the number of patients requiring renal replacement therapy far exceeded our CRT and bedside hemodialysis availability. So these are all patients in the ICU on ventilators, frequently on pressors. So the first thing, once you have geolocalized services, you can run the risk of having different teams having different thresholds for who's getting dialysis and who's not. So when you have geolocalized services and you don't have cross coverage, you have to recognize that there may be variations because sometimes there is subjectivity. There is also recognition that renal replacement therapy, indications change with the availability resources, right? So if you can hold off for a day on dialysis, you will. But if you have a device and the resource available, you may not. So the second thing we need to do was maintain consistency across teams. So we created a renal replacement therapy huddle that allowed us to determine, who needed renal replacement therapy for the day, plan resource allocation accordingly, and maintain kind of consistency in terms of triage decisions across teams. And then finally, there is the actual resource of the machine. So we recognize, since we don't have enough CRT machines for everybody, we would need to have a shared protocol where we had more than one patient using the same CRT machine. Now, traditional PERT or prolonged intermittent renal replacement therapy, which is frankly a term I'm not a fan of, but we're struggling to find a different term for it. It traditionally recommends using a 6 or 12-hour on-off cycle. The challenge with a 6 or 12-hour on-off cycle is that it dramatically increases machine downtime, and there's a dramatic increase in nursing burden when they're priming the machine and returning blood and dismantling or disconnecting a patient to get to the machine to the next. So we eventually arrived at a 24-hour on-off cycle. That compared to a 12-hour on-off cycle, it cuts the machine downtime by 50%, decreases the number of times that the nurses have to change. It cuts your discard of cartridges and filters by 50%. So in that resource crunch, those were choices that we made that were important. You also have to recognize that when you're sharing machines, there are logistical challenges of getting your machine from patient A to patient B. Now, the logical thing would be to take patients who are next door to each other in adjoining rooms or adjoining beds to say, okay, these are the two patients we're going to share a machine with. The problem is that we also have a high mortality rate. So those pairs are not stable, for one. Two, you may have units with an odd number of patients, so machines may need to leave a unit and go to another unit for a different day and then come back. So keeping track of where these machines are and where they're going to the neck, where they're headed after they are disconnected, was actually a full-time job that we had just one person managing, in addition to managing resources and consumables. So in order to be able to do this, so I know Dr. Mehta showed some of this earlier. So what we essentially did was we had to create a census tracker so we knew who was on dialysis, but where. We needed to monitor our supplies and the rate of consumption. So we created some dashboards to be able to do that. And then we created these shared protocol trackers that allowed us to identify which patients were sharing which machines, so that we knew where patients were going, and should a patient either die or have renal recovery and not require renal replacement therapy, it was quick to replace them. And then recognizing that as we did this efficiently, there would be times where if you had an odd number of patients, there were patients who may potentially, even at the peak of the surge, require true continuous renal replacement therapy. And so they would have a machine dedicated to them. So those sort of choices are facilitated by these tools. We've described these tools extensively in our publication AKI reports. And these tools are available for download for free from the site. A user guide that allows you to customize these, recognizing that not all institutions are quite set up the same way we are, and so every institution has its own unique challenge, is tracking consumables, right? So when you are running a protocol, the risk is that you're going to end up using a lot more dialysate. And dialysate for CRRT in particular is a challenge, right? It's high volume, it's difficult to transport. And so one of the challenges was actually transporting enough CRRT solution to New York City to be able to accommodate that surge that happened essentially across all hospitals simultaneously, till they essentially needed the US military to come in and fly in enough dialysate from Europe actually at one point. But before we got to that point, we recognized that there was going to be a challenge. And so what we ended up doing was creating these therapy bag limitations. So we don't use the Prisma-Sate machine. We use the Next Stage machine at Columbia, which from a nursing perspective is good because it allows you to spike multiple bags. Now, if you have a CRRT process ongoing for a patient and you spike 5 or 6 or 7 bags, it doesn't really matter, because what you're doing, of course, in a crisis mode, you are going to have to lower the treatment dose that you're being provided. So what we did here was essentially provide, at every morning, we would determine based on our supplies and what was available and what was going on, what our treatment dose for the day was going to be, allowing clinicians obviously to adjust this based on individual patient needs, which would then, at the time of turnover. So these tools are, again, this nomogram is available for download and can be used. Now, finally, what we ended up also doing was starting to run out of dialysate. So the easiest way that we found to generate dialysate was to use a regular hemodialysis machine. Now, this obviously required permission from the FDA, which we got given the crisis circumstances that we were in. And this is a relatively straightforward process if you keep certain things in mind. And we've described this. It is this spike port and a filling port that's separate. The most common of these are TPN bags. And so you use the filling port to actually fill the bag. Once the bag is filled, there's a inbuilt clamp on it that allows for seal. And then you don't use the filling port when you're using the bag, you can spike the port. That's the first key element to this. The second is, in order to override the alarms on a dialysate machine, you need a spare Hansen. You put it on the interlocked supply line. And when the hemodialysis alarm, so once you have a filter set up and the hemodialysis machine is generating dialysate every 5 minutes and then running the risk of contamination because you're not connecting and disconnecting these bags carefully, what we did was essentially create a DIN network with a Y chain. These are, the DIN connector is basically this connector that's a size that fits onto a regular hemodialysis filter. These are standardly available. You do male to female, you create a Y, you then have 4 bags. It's sort of changing bags every 5 minutes, you're changing it every 20 minutes. Which may not seem like a lot, but in the actual, in the midst of it, it's a much easier process, and you're able to keep these things stable. Now, to the point that Dr. Mehta brought up earlier, there is concern both for chemical stability and there's concern for microbiological contamination. So based on FDA recommendations, what we ended up doing was we changed out this circuit every day. We also took random bags that were sent to microbiology for endotoxin measurements. Our endotoxin measurements were consistently negative, and the chemistry is stable for at least 24 hours, which is what the FDA allows you to use for homebrew dialysate, so to speak. Now, the key aspect to this, however, and the fortunate part to this is we've recognized is that the incidence of AKI among patients with COVID is declining, both for those patients who are hospitalized and those patients who are severely ill in the ICU, ventilated. This is data from David Chariton's group that shows that clearly there was a decline over the first year. The reason for this decline, still is, I think, somewhat of a mystery. And what he's shown here is that even with that decline, however, AKI outcomes for individuals with AKI are particularly poor. So in summary, what I would say is that AKI surgeries require flexible renal replacement therapy delivery models. They require careful tracking of resources, consumables, census, patient census, if we're going to provide adequate care. And then if you have daily huddles across the teams that are providing this care, you can ensure a consistency both in the level of clinical care and triage decisions. It does leave open many important questions about the incidence of AKI. It's unclear why it was so high, but it also does raise important questions about the ARDSNet protocols and the impact that the aggressive volume control those protocols required, and their contribution to AKI. And I'll stop there. Thank you so much for your attention.
Thank you, Dr. Sumit. A lot of data you could present in such a short time. The last talk of the session is by Dr. Vivek Jha, again, a person who does not need any introduction to any one of us. He is from PGI Chandigarh and is the immediate past president of International Society of Nephrology. Presently, he is in Delhi as a consultant nephrologist. I request Dr. Jha to talk to us about the ethical consideration of dialysis in COVID. Thank you, sir.
Thank you, Rajashekar. Thank you for inviting me to speak with all of you this evening. Let me start by sharing my screen. I hope you're able to see my screen.
Yes, sir.
Thank you. So my talk is going to be somewhat different from the ones that you have heard so far, in that I'm not going to be necessarily focusing only on continuous renal replacement therapy or dialysis for acute kidney injury in COVID-19. But let me start by saying that nephrologists are not unfamiliar with ethical dilemmas so far as deciding about who to dialyze and who not to and how to is concerned. And this is a very, very old picture from the Life magazine in the 1970s when a panel used to decide who in US will go on chronic dialysis therapy. But COVID-19 has really taken us in a completely different dimension. So far as the ethical guidelines for delivering dialysis is concerned, in all advanced countries, it's been recommended that ethics mandates that access should not be a consideration to deny dialysis to anyone. And one should not worry about availability of resources, but make them available so that people who require and can benefit from dialysis or renal replacement therapy should do so. But COVID-19 impacted this principle very well and introduced a huge element of inequity in access to dialysis through a number of factors which are now very well known to us, but they were quite new almost 1.5 years ago. when COVID-19 was slamming into healthcare delivery services almost all over the world through supply chain disruptions, shortages of staff and personal protective equipments, patients being unable to travel during lockdowns, lab services being disrupted, many dialysis units being closed down, especially in countries like India, the unpredictability of demand and the need for rationing, which forced us also to think of providing dialysis to even fewer people than had access to dialysis so far. At that same time, healthcare workers were experiencing really a range of feelings. On one hand, they experienced a heightened range of autonomy, competence, and altruism because they were providing care beyond the call of normal duty to people with COVID-19. But on the other hand, they were also gripped with a huge amount of anxiety, fear, grief, and both physical and emotional exhaustion, which took a toll on their mental well-being. Recognizing that all of these, the three major nephrology societies from around the world, the American Society of Nephrology, the European Renal Association, and the International Society of Nephrology came up with this call to governments around the world and to multilateral societies to ensure that all of these responsible agencies provided support to staff, nephrologists, and other health professionals who were delivering life-saving dialysis treatments and making sure that there were testing capabilities and PPEs, and this is something which you have to remember that this was given out early in the pandemic when we were suffering from multiple crunches. But now, just to illustrate some of these points, let me present to you 2 or 3 cases. And here is a case, an actual case, a 48-year-old male, the sole breadwinner with 2 young children, who is known to have progressively worsening chronic kidney disease for the last 2 years. He was unable to access hospital care during the pandemic and developed advanced kidney failure and fluid overload and needed immediate dialysis at that particular point of time. Comes to you and you are managing a dialysis unit which has no provision for managing COVID-19 cases. And it's very clear that if this patient doesn't receive renal replacement therapy or dialysis in the next hour or 2, there is going to be a really bad consequence for him. Now, as was the practice in that time, that everyone was worried about COVID-19, and any patient who presented unbidden to a healthcare facility was asked to get a SARS-CoV-2 test, and SARS-CoV-2 tests were scarce at that time. So you are immediately faced with this question: should you insist on such a test in this patient? And this is like, just to illustrate that this is not a theoretical question, this was reality in a country like India and many other countries, where many of these patients who were told to get a COVID-19 test, because these tests were so scarce, they were not able to get it, and they often ended up dying, which was such a tragedy. And the people who had to deal with these patients really suffered some major ethical challenges. Here is a second case of an overwhelmed hospital which has just one available ventilator. There are 2 dialysis patients with COVID-19 who need ventilator support urgently. One of the patients is a 25-year-old male, unemployed, is on self-funded dialysis and has stayed at home until becoming critically ill. Whereas the second one is a 60-year-old female on dialysis from a well-off family with aggressive caregivers. Now, remember, there is just one ventilator and both of these people need it. One young person, second, not old, but somewhat older than this person, and who should be given the ventilator. You can see the dilemma that is in front of you. A third case is of an 82-year-old male on dialysis with respiratory failure due to COVID-19, and a decision is made not to ventilate this patient in view of the clinical situation, but the hospital has a policy of not allowing visitors, but the family petitioned for allowing an exception for end-of-life care. Now, should the dialysis team ask for an exception in this individual when others are not able to get it? These illustrate the challenges in fulfilling our ethical duties that we take for granted to our patients, but they became some things that were not easily available during the COVID-19 pandemic. And these are the principles shown in the different boxes that really are challenged by these situations, which include respect for autonomy, privacy, and confidentiality, and our respect for beneficence and non-maleficence, our duty of fidelity, respect for human dignity, and respect for justice. These are all ethical principles that we deal with on a day-to-day basis. There are a number of challenges that we faced in decision making. Clinicians obviously had much less information than usual. There was a huge amount of uncertainty regarding risks and benefits of available options, both dialytic and non-dialytic treatment options. There were communication challenges because of a number of reasons, not the least of them being no caregivers being allowed to come into the hospital. And all of this led to the healthcare workers facing a struggle to maintain balance between obligations to patients, their families, and oneself. And the inability to act in accordance with their own deeply held ethical beliefs owing to external factors produced a big push and pull. And this led to a consequence which produced moral dilemma, leading to moral distress, and finally, in some instances, even to moral injury, which was relatively long-lasting. What were the various sources of moral distress during the pandemic, which were all linked to kidney replacement therapies that we as nephrologists or kidney health professionals provide? The health systems were overwhelmed, the resources were limited. The policies and practices of clinical care were changing rapidly, and it was not certain that what we knew one day would remain valid the next day as standard of care or even current policy. And of course, this was all compounded, at least in the initial months, by fear for personal safety as well, until vaccinations had not become available. This led to a situation where we had to deal with what is called moral resilience, which is the ability to sustain or restore ethical integrity in response to morally complex situations, which leads to moral distress. And this distress is experienced when one feels unable to act ethically and is powerless to change the circumstances. This might be affected by a number of other factors, which have all been experienced by healthcare workers from time to time, including those who deliver dialytic care. These included unsupportive hospital leaderships. Nobody was prepared for this kind of situation. It's very fair to say. Social support was limited, and often there was a culture of silence on the part of a range of actors, which produced challenges. And all of this led to moral injury, which is the psychological, social, and spiritual trauma that results from these acts that transgress our ethical values. So then what do we do in this situation? In collaboration with a number of colleagues, which included ethicists, we put together this paper and published it in Kidney International last year, where we make some recommendations for dialysis decision-making during a pandemic. One of the most important things is to be always transparent and provide reassurance to not only the people who are immediately impacted, but the wider community through a number of actions that we can take. First of all, we need to acknowledge the challenging nature of decisions around the care of patients who are already on dialysis and patients who will require dialysis because they develop acute kidney failure. We have to keep the patients and carers informed of any new evidence and protocols that emerge on a regular basis, and we need to support their understanding in the entire team as well. We as leaders needed to establish systems to support continuity of care and communication between the teams that were delivering care and patients. And finally, we have to acknowledge that rationing is inevitable, but these considerations should be addressed separately from individual care decisions because they affect groups, not individual patients. We need to perform critical analysis. These are the four main things which require to be kept in mind while we do this analysis. We need to engage with the evidence in COVID-19 literature, but at the same time, we must contribute to evidence generation by involving ourselves in clinical trials. We have to evaluate evidence from different countries and different health systems in appropriate context. For example, something that is applicable in US or UK may not be applicable in India or Nigeria or South Africa because the circumstances and resources available are different. Now, the two most important were to use guidelines and other decision aids to avoid bias, but always consider application in the context of patients as individuals. This is something which is important, and it was easy to dehumanize individuals so far as this decision making is concerned. And finally, to ensure that there is broad acceptance of any rationing decisions, including by patient community wherever it was possible. Now, what were the recommendations that one can make for managing this risk and moral distress? The most important thing was to protect staff from infection, because that gives them the greatest strength, initially through PPEs and then through vaccines when they became available. We needed to acknowledge morally complex decisions, and we needed to seek support from colleagues when confronted with these situations. We should recognize the likelihood of moral distress amongst colleagues, and also in patients and their families, because they are also struggling with making or understanding these situations. And as a community, we need to actively support each other. There are a number of key strategies that can optimize utility and promote equity in allocation of limited dialysis resources. I'm not going to read all of them, but they range from extending capacity, using alternate modalities where possible, using transparent clinical criteria to inform decision making, engage in advanced care planning, what to do when COVID-19 strikes, because now we are in a different cycle of COVID-19 compared to where we were at the same time last year. But this question was very real, and people should have really been making these decisions with their patients who were on dialysis already, because they were at high risk of getting the infection. And so what to do in this situation should have been discussed beforehand. And prioritization of the development of guidelines to support decision-making for allocation of dialysis resources in all hospitals and healthcare systems. This required buy-in from all stakeholders, especially patients and their policymakers. And in the end, we all as a community need to be respectful for procedural justice all the time, which include transparent communication, systematic monitoring, review our outcomes continuously, and support accountability. Therefore, in conclusion, my dear friends, I would say that COVID-19 pandemic gave rise to complex ethical issues with specific implications for kidney healthcare during the pandemic. Dialysis allocation was particularly challenging in different parts of the world. Without support and guidance, the moral impact on healthcare professionals was profound. And it was really experienced by a whole number of people, as we all know, because we have spoken to each other. These challenges, mind you, are likely to persist because of the long-term effect of changes in healthcare practice, economies, and social norms. And more work is needed to explore these issues in greater depth and to develop guidelines and tools to support ethical decision-making in the local context. Because, as has been often said, COVID-19 is not the last pandemic that we are going to see. There will be one as sure as night follows day, and we need to be prepared for it. Thank you very much for your attention.
Thank you, Dr. Jha, for addressing a very difficult topic. That brings us to the end of the update that we have been learning since morning about AKI in COVID, starting from epidemiology, pathophysiology, treatment, then membranes, and of course, the ethical considerations finally. I request Dr. Mehta for his comments, and we'll try to wind up soon.
First of all, I'd like to thank Sumit, Thomas, Vivek, Valentin for this excellent session. You've all brought out some really pertinent and very practical issues related to managing patients with RRT in this pandemic. And I think that the lessons learned will be and can be applied as we go forward for this. I think the big question is for all of us is, as we look at the myriad of therapies that are now available to us, for the right patient at the right time is the challenge. And I think that given the logistics that we all face, both in terms of access to these therapies and also just the ability to build and to provide them, as Vivek has pointed out, becomes quite the issue for us to consider. So I guess my question to all of you is essentially, how can we move forward with respect to standardizing or at least providing a pathway for people to follow, given that we've got these pockets of information coming through, and how best can we synthesize this so that it's available to everybody to utilize. Maybe I'll ask Vivek to comment, since he's got the full education portfolio and the entire ISN portfolio, just to get a global perspective.
Thank you. No pressure, Ravi. Yes, look, I think the question that you ask is critical, and one of the things that helps is our sessions like these, because we learn from each other. I think what other colleagues presented, what Sumit presented, in the way they innovated and managed continuous renal replacement therapy, is not something that each of us needs to discover on our own. And so we need to learn from each other, and that's something which we saw happen a lot during the pandemic. There were profusion of education sessions, webinars, etc., and they were heavily attended. So I guess that helps. We need to learn and develop crisis standards of care. Of course, we always want to avoid crisis when possible, but I think developing crisis standards of care and keeping them ready is really important. Although we are limiting our discussion to kidney replacement therapy or broader kidney care, but I think the issue goes much beyond that. It's now been accepted around the world, despite knowing that a pandemic is inevitable. Almost all the countries fail, such as the United States, really were found to be wanting in big ways. So our definition of preparedness it needs to be really appropriate. We need to expand capacity, and we need to basically develop a system in which we talk to our colleagues, including talking to the general community as well. It's also been said repeatedly that healthcare system resilience is critical, and if the entire healthcare system is not resilient, then pockets are bound to fail. And we are, any healthcare system is identified by the least or the worst performing component of the system. This is an opportunity, and I think we should take this opportunity to prioritize development of guidelines by ensuring buy-ins for all stakeholders. And I think repeatedly, as I've said before, that equity is critical. And while we think of equity, we have to be mindful of procedural justice, communication. We need to develop appropriate monitoring mechanism and develop mechanisms that support accountability. Of course, the resources are different in different parts of the world, and that is not going to change in a hurry. But I think learning from what has been done in one part of the world and adapt it, because we have now some time, because Omicron obviously is much less virulent than the other variants that we saw. But if we use this, I think one of the mistakes that we can make is that we can say that life can go back to normal now. That's one message which we go with, that will be perhaps a lesson well learned.
Sumit, any thoughts on that?
No, I have to say, I mean, Vivek is very comprehensive, and I think he's absolutely right. I think the one thing I will add is that I think in general, the challenges with renal replacement therapy and care for patients with kidney disease was largely underappreciated before the pandemic. I think healthcare systems did not recognize just how both fragile the supply chain was for those sort of resources, but also the challenges that having kidney disease does in terms of a comorbidity burden. So there is much greater recognition of that now, and I think it's an opportunity for us to leverage that to gain kind of the resources that I think our patients deserve. And to Vivek's other point, I think he's absolutely right. Resources and thresholds are very different in other parts of the world. but I think there's an opportunity to learn here from each other. And I think Vivek's been particularly good, I think, at sharing kind of the the experiences and the lessons learned in the developing world. And I think the developed world, particularly the US and other parts that failed, I think have a lot to learn from what you can do with what we can learn from low resource settings and how we make those choices. And the last thing I'll say is that I think oncology is one part of the healthcare system that has done really well in terms of evidence generation for relatively rare diseases by allowing standardized protocols and aggregating patients, right? And I think we should take a leaf out of that book and see if we need to replicate that if we're going to move our field forward.
Thank you, Sumit. Thomas and Valentin, I guess the question I have for both of you is, you've both shown some very innovative ways of using adsorptive techniques and in their application. But I think what struck me is that essentially this has been catalyzed by the pandemic, in a sense, because before the pandemic, the application of these techniques was much more in a limited fashion. Now it's sort of become, okay, we have availability. And I think I point out two things here, which I would like you to please comment on. One is industry and what their role has been. And second is the regulatory agencies and what their role has been with respect to approving the technologies. And for example, Sumit saying they went to the FDA and got the dialysis production as authorized to do. So my question is, but all of those were for emergency use. So how can we now take it one step further so that we continue to innovate from that and not stop at just this point in time?
Yes, Ravi, I fully agree that this pandemic was the good thing about this is like it's regarding these blood purification techniques that they were highlighted, and at the very beginning when there was this cytokine storm syndrome, and all these people saying that the inflammatory response is so huge that we need to test all these techniques. That was a good point, because all of these companies came to us and say, okay, we have this device, we need to try this device, it works. Although there were only some very preliminary data from their labs, they say, yeah, it works, it's removing the SARS-CoV-2, you should try this technique. So that's what we've done. We started to do some observational studies, slowly case series, and we looked at the inflammatory parameters, we looked at the hemodynamics in an observational way without any comparison with the control group. And that maybe now, as I said before, we need to go a little bit further and compare the different techniques. And of course, one single center cannot use all the different techniques. As you said, there are many modalities. We've seen that they are not exactly the same. Some of them target endotoxin, some of them target the cytokine, some of them target the bugs, the virus. So I think that the best would be that if you are a big center and then you can run a lot of studies, then you need to participate to these studies and to run protocols. But if you work in a small center, just say, okay, go to these people, go to the investigators and say, okay, we are available, we can participate to one of your studies, and then you need to pick one of the techniques, either the Seraph, either the Oxaris filter, either the Cytosorb, and then we can find other centers that can participate to all these studies, because we don't have so many. The numbers in these studies are not so huge, only like case series of 10, 20, 30, 50 patients. And I think, well, in my case, we need to find other centers who are okay to participate. And there are not so many centers, and all the teams, the nurses now in the ICU is difficult to find. So it's difficult for them to implement new techniques. They do not want to implement new therapies. The nurses, it's difficult for them to masterize all the different therapies. So one by one, once if you live if you work in a small center, I think only one technique, one modality, and then try to participate to the different ongoing studies in big centers.
Valentin, your thoughts?
Yeah, thanks. I think, what had happened was the pandemic spurred on the use of these, because prior to that, every single study which targeted these techniques of removal of inflammatory mediators in sepsis was a negative study till then. And I had actually started to lose a little bit of faith, because here in India, for one thing, all these techniques are very expensive. Oxiris is about 65,000 rupees for the filter, and the hemophil was 30,000. We were lucky in that Torre provided us with all the hemophil cartridges free of cost to use. And they didn't put any pressure for a study. So we were able to plan our own study. We said we'll do just observational studies. We also, because of that, though there was DCGI approval as early as 6th May, May 2020 for the use of cytosol, we didn't go for cytosol and Jafron. We said we will use these techniques, and that meant we used Oxiris and hemophil only in patients who have a conventional indication for renal replacement therapy. And what we get of targeting of removal of cytokines, inflammatory mediators, etc., is going to be a bonus. So we used Oxiris and hemophil in patients who had pulmonary edema, hyperkalemia, acidosis, etc. That's what we did. And Dr. Vijay Verma in Hyderabad was talking to me continuously. So I think he had a fair number also. In 2020, September, in the West Zone, we had a discussion. We said we must do a multi-center study, but unfortunately, that's where it stopped. We didn't go further with it. So it's time for us now at least to plan for it.
As Dr. Lobo mentioned, Hyderabad saw a huge spurt in use. I am personally aware in our own group, Dr. Vijay Verma, Dr. Krishna Patil, together more than 100 sessions of these membranes. Outside the group also, there was at least data from 57 patients who were on the membrane. So I think it's high time to collate the data and publish it. Dr. Jha has raised his hand.
Look, I was just on that point, I was going to actually re-emphasize something that both Sumit and Thomas mentioned earlier, is the need to generate evidence. I had alluded to that also in my talk. I have to say, I'm sure all of us will admit that despite the fact that dialysis is one of the earliest innovations in the field of medicine, but since its inception, there has been relatively little innovation or development in dialysis until I would say, what we saw in the last 2 years. I think there has been more innovation in the delivery of dialysis in the last 2 years than has been in the past. And what we need to do is to really keep this momentum going. That was one of the questions Ravi asked, what can we do better? We need to do more studies. We need to generate more evidence, not just in the area of dialysis delivery, but even in the rest of kidney care. The fact that kidney disease or nephrology is the proud holder of the wooden spoon in clinical trials, that slide has been shown perhaps more than any other slide in nephrology meetings, and we need to change that. And this should be one of these opportunities. I think, for example, Valentine and Rajshekhar, etc., you talk about your experience. And if we don't systematically monitor and report these outcomes, all this experience will get lost to the posterity. And so it is our equally important responsibility, as important as providing care to individual patients, to transparently report, monitor and report these outcomes so that the rest of the community can also benefit from it.
Yes, sir. Fully agree. We should do. So that brings us to the close of today's learning. My sincere thanks to all the faculty from morning till now. On the 26th of Jan, a Republic Day, we have gathered to learn so much from each other's experience. There were more than 300 delegates who had logged in at various points and more than 300 registered. I'm hoping we will be able to bring out a document. We had discussed about this because so much of rich experience from each faculty which has been presented. And we will be shortly sending a mail to all of you asking for a write-up, and then we'll try to compile it. Anything else from the chair, Dr. Mehta?
No, I echo Raj's thing. First of all, thank you all for taking time out of your busy schedules on a weekday where to share your knowledge and your expertise. I think this is a great opportunity for us to reflect. We are 2 years into this pandemic. It's not over. We still have a lot ways to go. But I think that if we can keep this momentum of innovation and collaboration and collegiality, I think we can probably prevail on improving care for everybody around. So thank you all for joining us. We really look forward to continuing to work with you and seek your expertise. Thank you.
Thank you. We will close with the national anthem.
Thank you all.